I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the 39 Sleeps Till Christmas Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
So grab your preferred drink of choice or your trainers, clutch your pearls, and let's start with the headlines. Here's what's coming up this week. The hot topic of HRT, bleeding and endometrial cancer, just got even hotter, with lots of media coverage highlighting concerns about the risks of higher dose estrogen, sometimes prescribed off licence. This just might have triggered a few phone calls and e-consults.
Big changes in the UK vaccination schedules. Did you know over the past year there have been significant changes in the UK vaccination schedule? It's a fast-changing area. We're here to help you refresh and update your knowledge.
And here's what's coming up next week. Mpox. What do we need to know? In August 2024, the World Health Organization declared Mpox a public health emergency of international concern. Our authors promptly set to work updating our original article from 2022 so that we can share it with you.
Ovarian cancer, genetic risk. Ovarian cancer is difficult to diagnose at an early stage, and we do not have an effective screening programme. Reducing the risk of ovarian cancer death with risk reduction surgery is an alternative for some at higher genetic risk of the disease, and is now recommended by NICE. Listen next week to find out how.
The gut microbiome, cutting through the noise. In this pearl, we unpack the growing understanding of the importance of the gut microbiome, why it matters, and future practical applications. So let's start with HRT, bleeding and endometrial cancer, as the media coverage for this went through the roof. Now, this one took me 18 minutes and 4 whole seconds to read, so a latte and a comforting slice or two of fruit toast would be our recommended pairing for this one. I'm now a fully trained pearlier, so I'll be recommending food and drink pairings to go with our pearls. Now, we released this pearl in response to the media coverage that week back in October, highlighting concerns about the risks of higher dose estrogen, sometimes prescribed off licence. We felt this just might have triggered a few phone calls and e-consults, so we wanted to help. Fortunately, the BMS, in association with the RCOG, recently published guidance to support us in assessing and investigating unscheduled bleeding in HRT. So what did this one mean for you, Ali?
HRT is just hard, isn't it, Nick? I mean, I find it complicated knowing what to prescribe and then how to respond and troubleshoot to issues like bleeding, how to make sure that we're doing it all safely. And then you add on to that the extra layer of the fact that the women who are coming to us with these problems are often really suffering with their symptoms, sometimes feeling stigmatized. It's just an area that I feel like you need to be on the top of your game to manage. So yes, I think great advice that we need to do our little bit of GP housekeeping before we get into this, have our lattes and our fruit toasts and be ready and comfy and relaxed.
Exactly. And also, you know, it probably goes without saying, but the Women's Health team do the Women's Health course and they cover all this in much more detail. So if it's something that you kind of struggle with,
yes,
or you think, I really want to know more about that, then it's really worthwhile having a look at one of their courses. Now, in 2024, the British Menopause Society, in partnership with the RCOG, the British Gynecological Cancer Society and other associated bodies, published a guideline on the management of unscheduled bleeding on HRT. The guideline focused on 3 things: prevention, assessment, and management. Prevention, optimizing HRT prescribing to prevent problematic bleeding occurring. Assessment, guiding investigation and referral of bleeding issues based on endometrial cancer risk stratification. And management, giving evidence-based strategies to manage persistent bleeding. The written pearl summarises the assessment and management part of the BMS guideline, focusing on the information relevant to primary care. There's a separate article on HRT regimes and endometrial cancer risk, which looks at optimal HRT prescribing. We covered this on our podcast a few episodes back in the episode entitled HRT Regimes and Progestogen Dosing, Time to Change Our Practice. For more detail or specific information, have a look at the original guidance, which is the BMS Management of Unscheduled Bleeding on Hormone Replacement Therapy. Other sources used will be referenced as we go along. So Ali, why is unscheduled bleeding on HRT important?
Well, Nick, the short answer is that, as we all know, bleeding is a common side effect of HRT, and the assessment, investigation and management of unscheduled bleeding can be tricky. And what we really don't want to miss is endometrial cancer. So let's go a bit deeper. So as I just said, bleeding is a common side effect of HRT. And the rise in HRT use in recent years means that women are experiencing relief from distressing and disturbing menopausal symptoms, which is brilliant. However, unscheduled uterine bleeding, because it's a common side effect of HRT use, this increase in use has also led to increased numbers of women experiencing troublesome bleeding, which is not so brilliant. And this in turn has led to an increase in gynecological referrals for abnormal bleeding. And actually, urgent referrals through the suspected cancer pathways increased by 43% between 2021 and 2024. But interestingly, this rise was not accompanied by increased endometrial cancer diagnoses.
So just to dig a bit deeper, Ali, what did you mean when you said that the assessment, investigation and management of unscheduled bleeding can be tricky?
Well, the mechanisms that lead to unscheduled bleeding on HRT are poorly understood. We know that perimenopausal and menopausal women are prone to bleeding issues due to their endogenous hormonal fluctuations, which might cause or exacerbate bleeding. And older women are also more likely to have gynecological pathology, including endometrial cancer, which might also present as abnormal bleeding.
Yes, and I'm sure we'd all agree that we don't want to miss endometrial cancer.
Absolutely. Endometrial cancer is the fourth commonest cancer in women, and incidence increases with age. However, the age-related risk in newly menopausal women is low, so only about 0.7% in those aged 50 to 54 and 1.2% in those aged 55 to 59. And sequential HRT regimes may be associated with an increased risk of endometrial cancer when used beyond 5 years, whereas in contrast, continuous combined regimes are associated with a reduced risk of endometrial cancer compared to baseline. So here's a question, Nick. What are the normal bleeding patterns around perimenopause?
Okay, I'm not falling into that trap because there is no normal, but thanks for asking. Now, perimenopausal bleeding patterns may become progressively lighter or heavier, infrequent or more frequent, according to fluctuating hormonal levels. We should arrange further investigation along the appropriate pathway if a woman reports persistent intermenstrual bleeding, usually for more than 3 months, persistent irregular bleeding, infrequent heavy bleeding in the presence of obesity or a history of PCOS, postcoital bleeding, postmenopausal bleeding occurring more than 1 year after the last period, or heavy bleeding associated with other symptoms such as pain or pressure. And that's from NICE, so NG12 from 2015, updated in 2023, and also NG88 from 2018, updated in 2021, and also from Obstetrics and Gynecology International from 2014.
Okay, so let's look at the causes of abnormal bleeding on HRT now. And this is from The Obstetrician and Gynecologist, published in 2019. So the estrogen component of HRT causes endometrial proliferation, and the progestogen suppresses growth and induces endometrial atrophy and therefore stops bleeding. Erratic bleeding is common in the first 6 months of HRT use or within 3 months of a change in dose, affecting around 40% of users. So that's really common. Mechanisms that lead to abnormal bleeding on HRT, as we said, are poorly understood and may relate to things like hormonal stimulation of existing pathology. We're thinking about here things like endometrial polyps, hyperplasia, ovarian cysts, and also cancer. Poor compliance with treatment can also be a cause, or malabsorption of treatment. There might be drug interactions, for example, with enzyme inducers. And we might see the combined effect of HRT and endogenous estrogen production stimulating the endometrium, for example, in women living with obesity. And vascular and endothelial factors in the endometrium might also play a role. So, Nick, how do we approach assessment and investigation of unscheduled bleeding on HRT?
Well, Ali, prevention is always better than cure. And so in the prevention of problematic bleeding, then prior to starting HRT, we should ensure that any pre-existing bleeding issues are investigated and fully managed, that we choose the correct type of HRT, so sequential or continuous regimes, and an adequate progestogen regime is given to match the dose of estrogen. Now, you can have a look at the article on Red Whale Knowledge on HRT regimes and progestogen doses for guidance on progestogen regimes, or go back and have a listen to our recent podcast episode on this. The written poll on HRT, bleeding and endometrial cancer has some really useful flowcharts which summarise the BMS guidance on the investigation of unscheduled bleeding on HRT. There's limited data looking at the rates of endometrial cancer in women who experience unscheduled bleeding on HRT, and the BMS has therefore adopted a pragmatic approach based on risk stratification for endometrial cancer, although this is also based on limited evidence. The BMS divides endometrial risk factors into major and minor to guide appropriate investigation of abnormal bleeding in different HRT users. So the major risk factors for endometrial cancer are having a BMI of 40 or more, genetic risk, for example, Lynch syndrome, unopposed estrogen use for more than 6 months, prolonged use of sequential regimes for more than 5 years in women aged 45 or more, inadequate progestogen use in a sequential regime for 12 months or more. And just to clarify, the inadequate progestogen use in a sequential regime for 12 months or more would be tricycling HRT and giving quarterly progestogen, using less than 10 days of medroxyprogesterone acetate, so MPA, or norethisterone per month, or using less than 12 days of micronized progesterone per month. Minor risk factors for endometrial cancer are having a BMI of 30 to 39, anovulatory cycles, for example with PCOS, diabetes, unopposed estrogen use for 3 to 6 months, inadequate progestogen dose for estrogen dose, including an expired IUS for more than 12 months, inadequate progestogen dose in a sequential regime for 6 to 12 months, which would be, again, tricycling HRT and giving quarterly progestogen, using less than 10 days of medroxyprogesterone acetate MPA or norethisterone per month, or using less than 12 days of micronized progesterone per month. So try and remember those major and minor risk factors for later.
To pick up on what Nick was saying just now, if we look at the initial steps and assessment of women with problematic bleeding on HRT, prior to starting HRT, we should ensure any abnormal bleeding patterns are investigated and managed. We should start with a low dose preparation and titrate according to symptoms. We should counsel patients that some erratic bleeding can occur in the first 6 months of treatment, and that beyond 6 months, they should expect the following bleeding patterns, depending on what we've prescribed. So if they're on a sequential combined regime, they should expect a light cyclical bleed at the end of the progestogen phase. And if they're on a continuous combined regime, they should expect amenorrhea. And if despite all that, the patient presents with unscheduled or unexpected or unacceptable bleeding on HRT, then as always, it's back to basics, and the history and the examination are important. So thinking about the history, we should ask about the current bleeding pattern and what the pattern was prior to starting HRT. We should clarify what HRT regime the person's been on and how long for, and is there good compliance? And then we should ask about other gynae symptoms, for example, pain, dyspareunia, and importantly, we need to think, are there any endometrial cancer risk factors? And also, is the patient on other medications such as contraceptives or enzyme inducers? And then thinking about examination, we need to do an abdominal, a pelvic and a speculum examination. We need to take a smear if it's due, and swabs if necessary. And we need to consider a pregnancy test. And it's worth checking the BMI as well when we're thinking about endometrial risk factors.
Now, I just ran through the major and minor risk factors for endometrial cancer. So if the patient has one major or more than two minor risk factors for endometrial cancer, then we would refer via the urgent suspected cancer pathway. We'd also want to manage their bleeding, so we'll discuss our HRT optimization table shortly. Now, if the patient doesn't have any major risk factors for endometrial cancer or does not have more than two minor risk factors for endometrial cancer, then we can further investigate in primary care. If we investigate further in primary care, then the key questions are, does the patient have prolonged, persistent or heavy bleeding? Has the bleeding occurred or persisted after more than 6 months of HRT use or more than 3 months following change in dose or preparations? Does the patient have two minor risk factors for endometrial cancer? If the answer is yes to any of those questions, then we should arrange an urgent transvaginal or TV ultrasound scan. Once the patient has had their urgent TV scan, we need to ask ourselves, are any of the following features present? An endometrial thickness of more than 7 millimeters on sequential HRT, endometrial thickness of more than 4 millimeters on continuous HRT, or the endometrium incompletely visualized, for example, due to the presence of an IUD, fibroids, or post-ablation. Now, if the answer is yes to any of those features, then we should refer urgently on the suspected cancer pathway. If the endometrium is incompletely visualized on scan, but the area measured is within normal limits, then we should refer urgently to gynecology for a 6-week appointment.
Yes, and we would strongly recommend that you have a look at the flowchart in the article to cement what we've just said. It's really useful. There's another lower risk arm to the flowchart that we're not going to discuss here because we don't want to lead to any confusion, but it's all there in the Pearl and it's free to download for 3 months after the release of the written Pearl. So make sure you have a look at it as soon as possible because we don't want you to miss out. And when it comes to the management of bleeding issues on HRT, we can look at HRT optimization, which is also presented in a handy table in the written Pearl. General advice and options would be to address any modifiable risk factors. So we're thinking about things like weight loss that might reduce bleeding and also risk of endometrial cancer. And we could offer an IUS as the progestogen component if that's appropriate or desirable for the person, particularly if they are at increased risk of endometrial cancer. And we could also reduce the estrogen dose of the HRT. If the patient's on a synthetic progestogen, so norethisterone or medroxyprogesterone acetate, we could change to a regime with an alternative progestogen and have a look at the article on HRT regimes and progestogen doses for more on that. If we're using a transdermal preparation, if it's appropriate and safe, we can offer a switch to an oral preparation because they're associated with less bleeding risk. And we could also consider offering an additional oral progestogen alongside a combined preparation for a 3-month trial. And that includes women with an IUS. We could also suggest using micronized progesterone vaginally rather than orally. That's on an off-license basis. And if examination suggests vulvovaginal atrophy might be the cause of the bleeding, we could offer vaginal estrogen.
Now, compliance issues should also be addressed, and so we should ensure that the patient is using the product correctly and consistently. We should also ensure adequate progestogen is being taken with the dose of estrogen. We could also consider moving to a regime that's easier for the woman to remember. So depending on the individual, this might mean a transdermal patch, which requires once or twice weekly application, or a daily regime. If on a split regime, so non-combined preparations, then the patient could either switch to combined preparations, for example, combined patch or pill, which may be more practical, or take the oral progestogen at the same time as applying the estrogen gel or spray to reduce bleeding.
And then some more options just for sequential combined HRT users. If they're under 50 and there's no contraindications, we could consider switching them to a combined hormonal contraceptive as their HRT, bearing in mind that combined hormonal contraceptives are not licensed for people aged 50 and over. Or if you've got a sequential combined HRT user on micronized progesterone, You could increase the progesterone to 300 milligrams a day sequentially, or increase the number of days taking progesterone, for example, to 14 days of a 28-day cycle. Or you could change their progesterone to a synthetic progestogen, like norethisterone or MPA. Or you could offer desogestrel in addition to micronized progesterone at a dose of 75 micrograms, or instead of progesterone at a dose of 150 micrograms. That's on an off-license basis.
If the patient is a continuous combined HRT user, then if they're on micronized progesterone, then we could recommend a daily regime of 100 milligrams rather than the licensed dose of 25 days per cycle. So this would be off license. We could also consider changing to a synthetic progestogen such as norethisterone or MPA, or we could consider increasing progesterone to 200 milligrams a day. Again, that's off license. If a continuous combined HRT user is recently post-menopausal, we could switch to a sequential regime for 6 months. Now, we've mentioned off-license a few times now, and any off-license prescribing should be fully discussed and documented. We should consider review at 3 months and reducing doses back to licensed regimes if tolerated. If off-license regimes are continued long-term, then we should counsel patients about any additional possible risks such as breast cancer or VTE.
So thinking about intrauterine systems, Mirena is the only IUS currently licensed for endometrial protection with HRT, and this license is for 4 years. However, evidence shows that all brands of 52 milligram IUS provide endometrial protection, and that's for up to 5 years. So the British Menopause Society recommends that any brand of 52 milligram IUS may be used for endometrial protection for up to 5 years. But if new onset bleeding occurs with an IUS after 4 years of use, we can change the IUS for a new device after pathology's been excluded, which in practice means an examination and a transvaginal ultrasound, or referral for further investigation if other symptoms or risk factors are present.
Now, an IUS can also be malpositioned. A malpositioned IUS is one that is located more than 2 centimetres from the uterine fundus or is partially or fully displaced into the cervical canal. If a woman experiences bleeding on HRT and has an ultrasound scan which shows the IUS to be malpositioned, then the BMS suggests that the IUS should be replaced. Although there's no data showing that a non-fundally placed IUS is less effective, it may provide more irregular endometrial suppression and could be more likely to cause breakthrough bleeding.
So Nick, you were talking about endometrial thickness on ultrasound earlier, so I thought to finish off it would be helpful to run through the figures and the actions for endometrial thickness. So if a patient has no endometrial cancer risk factors, and their endometrial thickness is less than 10 millimetres, then they can be offered an increase in progestogen as part of the HRT regime. The BMS does not suggest rescanning asymptomatic women routinely after HRT adjustment. And if a patient has no endometrial cancer risk factors and their endometrial thickness is 10 millimetres or greater, then they need an urgent gynecology referral, and that's within 6 weeks.
If a patient has 1 major or 2 minor risk factors for endometrial cancer, and if you missed them when we said them earlier, then feel free to skip back and go over them again or have a look in the written pearl. So if a patient has 1 major or 2 minor risk factors for endometrial cancer and an endometrial thickness of either more than 4 millimetres on continuous HRT or more than 7 millimetres on sequential HRT, then we should refer them via the urgent suspected cancer pathway and increase the progestogen dose in their HRT regime.
If a patient has 1 major or 2 minor risk factors for endometrial cancer and their endometrial thickness is 10 millimetres or greater on any regime, then those patients need referred via the urgent suspected cancer pathway.
So, here are your learning points for approaching and managing problematic bleeding on HRT. Unscheduled bleeding on HRT is common, especially in the first 6 months of use. We should manage any pre-existing bleeding problems prior to starting HRT and ensure that the regime is appropriate for the stage of menopause and that adequate progestogen is given.
Initial assessment of bleeding involves history, examination, and assessment of endometrial risk factors. Further investigation and referral pathway will depend on endometrial cancer risk, nature of bleeding, and duration of HRT use. First line investigation is transvaginal ultrasound to look for pathology and to look at the endometrial thickness.
Endometrial thickness on sequential HRT should be 7 millimeters or less, and on continuous combined HRT should be 4 millimeters or less. Most unscheduled bleeding caused by HRT can be managed by altering the dose, type or regime of hormones. So 1 down, 4 more to go this month. Whew. How are you going, Ellie?
I'm doing well, thank you, Nick. I've got a bit of a ridiculous injury to complain about, actually.
Oh, no.
I was at the wedding of a friend this weekend and got pretty stuck in on the dance floor. And during Bohemian Rhapsody, I put my back out.
Oh, no.
So apologies if I need to get up during the recording at all and have a little stretch. But it was very worth it. I had a lovely time.
Oh, bless you. Well, I'm sure it was a good performance. Is there any video of it?
Yeah. I hope not.
Oh, well, shall we, on that note, let's move on to our next poll. So have a bit of a wriggle in your chair if you need to. And did you know, over the past year, there have been significant changes in the UK vaccination schedule. On the 1st of September 2024, a new RSV vaccination programme was introduced for older adults and in pregnancy of 28 weeks or more. It's now also recommended that pertussis vaccination is given during pregnancy at 20 weeks. And next year is the planned introduction of varicella vaccination in combination with MMR at 12 and 18 months. So there's lots of things going on there. Now, our written poll on this is the full vaccination schedules article from Red Whale Knowledge. So if you read the whole thing, it's quite an undertaking, and it took me about 28 minutes and 16 seconds to go through. So you'll need a picnic hamper, a flask of tea, and all sorts of things to get you through that one. But don't panic, we're going to focus on the new stuff here. So what did this one mean for you, Ali?
Well, Nick, this might sound a bit cheesy, but when I was reading this and thinking about all the changes, I had a little moment to myself of, wow, isn't it brilliant that as a society we've worked out how to prevent all of these diseases?
Yeah.
It doesn't really feel like the most glamorous thing in the world, sort of spending your Saturday morning doing RSV vaccinations or whatever. But actually, that's preventative medicine. It's the best, isn't it? So, yeah, it's just something to, marvel at, really.
Yeah, it's a wonderful thing to look at, isn't it? So let's start by looking at the planned changes to the UK childhood immunisation schedule. Now, in November 2023, the Joint Committee on Vaccination and Immunisation, so let's call it the JCVI from now on, they released guidance on planned changes to the UK childhood immunisation programme. And there are 3 main changes. Firstly, varicella, the introduction of the varicella vaccine, and this is to be given as a combination with MMR in a new MMRV vaccine. The second change is to MMR itself. So with MMR, there will be a change to the ages when the MMR is given. The new combination MMRV will be offered at 12 months and 18 months of age, so earlier than the existing preschool booster of MMR. And the third main change is with meningitis, because there's a change to the meningitis vaccination programme. An additional dose of the Hib-containing multivalent vaccine, usually given earlier in infancy, will be given at 18 months. And we will no longer be giving a Menc booster at 12 months. The existing preschool booster of diphtheria, tetanus, pertussis and polio will be unchanged. The rationale? Well, the changes in meningitis vaccination are due to the withdrawal of the Hib-Menc vaccine that's currently being used, and that is the Menitorix vaccine, and there is no equivalent vaccine available, hence an adjustment is needed to be made to the programme here. Now, it's anticipated that bringing forward the second dose of MMR may improve uptake because this has been shown in previous outbreak responses in London. Successful adolescent uptake of the meningitis C vaccines, the MenACWY at age 14, has shown good indirect protection for infants against meningitis C. This, along with a significant reduction in prevalence of the disease, has led to the JCVI decision that the Menc booster at 12 months is no longer required. The overarching aim of the Hib vaccination is to achieve herd immunity rather than individual infant protection, and the decision to boost this at 18 months is to bring this dose in line with the rest of the vaccination schedule. These changes will be introduced together when supplies of the Hib-Menc vaccine Menitorix are exhausted, which the JCVI anticipates will happen in 2025. Until this occurs, we should continue to follow the existing schedule outlined in the table in the written Pearl, and the Green Book has not yet been updated.
So let's look at immunisation for respiratory syncytial virus now, or RSV. So a pre-COVID Lancet systematic review of worldwide RSV mortality found that 1 in 50 deaths worldwide in children aged 0 to 60 months were caused by RSV, and that rose to 1 in 28 deaths in children aged 28 days to 6 months. So from the 1st of September this year, the UK HSA has introduced 2 new RSV vaccination programmes. One for older adults and one for those who are pregnant. And the aim of the vaccination schedule in pregnancy is to reduce RSV infection and morbidity in infants through maternal transmission of immunity. The recommended vaccine for both of those programmes is Abrysvo, which is an inactivated bivalent recombinant protein vaccine. There is no animal content in the vaccine, and the only contraindication is known anaphylaxis to the vaccine or its ingredients. If individuals are acutely unwell with fever, vaccination should be delayed until recovery, and as this is a newly licensed vaccine, any adverse reactions should be reported via the yellow card scheme. The aim of the vaccine in older adults is to reduce the incidence and severity of RSV infection with consequent reductions in the number of people going into hospital. So we should offer the vaccine to all adults turning 75 on or after the 1st of September this year. And there will also be a one-off catch-up campaign for those who were aged 75 to 79 on the 1st of September. And as we plan the logistics of how we're going to deliver this vaccine, it's important to know about its use with other vaccines. So ideally, the RSV vaccine should not be given at the same time as the seasonal influenza or COVID vaccinations in older adults. However, we can use them together if there's a specific clinical need. For example, we believe the patient might not return for a second appointment. And the JCVI doesn't recommend a specific interval between RSV vaccination and other immunisations. So moving on to pregnant people and the logistics there. From the 1st of September, we should have started offering the vaccine to all women who are 28 weeks or more into their pregnancy up to birth. And we should offer it in each pregnancy, regardless of the interval between pregnancies. And trial data presented by the UK HSA showed that vaccination of mothers was 70% effective at preventing severe RSV in infants for 6 months from delivery. There was a slight non-statistically significant increase in preterm delivery in women who had received Abrysvo, but no increased mortality, and the JCVI did not have safety concerns about the use of the vaccine in this group. Again, it's important to know about its use with other vaccines for logistical reasons. So ideally, there should be a gap between administration of the pertussis vaccine at 20 weeks gestation and the RSV vaccine at 28 weeks gestation. There is some evidence suggesting that the effectiveness of the pertussis vaccine might be reduced if the two vaccines are given together. However, the JCVI advises that they can be co-administered if necessary. For example, if, like with older adults, we're concerned that someone might not return for a later vaccination appointment. And in pregnant women, unlike in older people, the JCVI does not recommend separation of seasonal influenza, COVID and RSV vaccines. So Nick, what can you tell us about childhood varicella zoster vaccination?
Well, Ali, in November 2023, the JCVI reviewed and updated the guidance on varicella zoster vaccination in children. The view of the committee was that routine childhood immunisation against varicella zoster should be offered to children in the UK in a 2-dose schedule. This is a change from previous guidance in 2009, which felt the vaccine was not cost effective. So let's consider the planned schedule. The JCVI advises a combination vaccine of varicella with MMR, so MMRV, to be given at 12 and 18 months of age. It's recommended a single-dose catch-up program for children over 18 months, up to and including 5 years of age.
And what's the rationale behind this, Nick?
Well, it was previously thought that exposure to circulating varicella infections in children boosted the immunity of adults against varicella and therefore reduced the risk of shingles. But more recent data from Cambridge reviewed by the JCVI indicated that this effect has been overestimated. Worldwide data from existing vaccination programs has shown a significant reduction in varicella-related hospitalization, including indirect effects on infants in the younger cohort not yet eligible for vaccination. A Bristol-based study looked at the impact of childhood chickenpox on quality of life in children and the impact on work and education for children and their caregivers. It found that complications from chickenpox are costly, common, and place a burden on health services and also on employers. This, along with a reduction in the cost of the vaccine, led to the JCVI advising that this vaccine is now cost-effective. The decision to use a combination MMRV vaccine was made to avoid the need for multiple injections. Studies have shown a small increase in the risk of febrile seizures following a vaccination where the MMRV is given compared with giving MMR and a separate varicella vaccine at the same time. This increased risk is small, with CDC data estimating that approximately one additional event per 2,300 doses given, and this risk was felt to be acceptable by the JCVI.
So, if you would like to go through the entire immunisation schedule for children born on or after the 1st of February 2022, then there is a table in the Written Pearl that you're very welcome to look at, but we're not going to go through all of that here. So, as we've discussed, the JCVI has advised changes to the childhood vaccination programme, which will come into place sometime in 2025. We've not made changes to our vaccination schedule table yet, as currently, until 2025, this remains the recommended UK childhood immunisation schedule. So we'll update the table on Redwell Knowledge when the schedule actually changes. And there is also a really useful table in the Pearl which features additional vaccines for people with underlying medical conditions such as asplenia, cochlear implants, haemophilia, to name a few. So it's worth knowing that that is there. And if you have access to Redwell Knowledge, you can go back to it at any time.
Yes, and one of our listeners has recently been in touch and asked us if we had any advice on vaccine hesitancy. So it's great to be able to say that this is covered at the end of the Pearl. And indeed, no feature on vaccines would be complete without a discussion on the tricky topic of vaccine hesitancy. So we've based our summary of this on a 2023 BJGP editorial. Now, in 2023, all UK childhood vaccination levels were below the recommended 95% coverage for herd immunity.
So thinking about the definition of vaccine hesitancy, that phrase describes the motivational state of being conflicted about getting vaccinated, which may lead to delay in vaccination or refusal of vaccines despite there being availability. And around 20 to 30% of the UK population describes themselves as vaccine hesitant, and rates are only slightly lower than this in medical professionals. Vaccine hesitancy is less extreme than being anti-vaccine. So only, less than 2% of the population describe themselves as being anti-vaccine. Whereas vaccine hesitant individuals, that's that 20 to 30% of the UK population, are theoretically persuadable to considering vaccination.
Now, vaccine hesitancy is influenced by individual and societal understanding of health, social and cultural factors, public health policy, past experiences, and by the perceived risk or importance of having or avoiding the vaccination. As individual clinicians, we're unlikely to be able to influence many of these factors. However, we can make the individual feel understood and create a personalised response to their concerns.
Yes, and we might be a trusted individual to the person or be able to adapt our approach to our own local communities. So we can rethink our consultation style, and we might consider moving from an information-giving approach towards a more relational discussion, perhaps using motivational interviewing techniques. So it might be worth having a look at our article on Redwell Knowledge about motivating behaviour change. And if you play a role in increasing vaccine uptake at practice, PCN or ICS level, there is an open access paper about strategies to engage with high risk and hesitant communities, which you might find useful in starting discussions. That was published in the Paediatric Infectious Disease Journal in 2022. And you can click on the link in the written pearl. And we'll also put a link to that paper in the show notes.
So here are your learning points for the big changes in the UK vaccination schedules. There is a planned 2025 introduction of a varicella vaccination to be given as a combination with the MMR in a new MMRV vaccine. The new combination MMRV will be offered at 12 months and 18 months of age.
An additional dose of the Hib-containing multivalent meningitis vaccine, usually given earlier in infancy, will be given at 18 months. We will no longer be giving a men's C booster at 12 months. And if in doubt, check the Green Book online, because things change fast in immunisations.
A new RSV vaccination programme has now been introduced for older adults and in pregnancy. We should offer the vaccine to all adults turning 75 on or after the 1st of September 2024. There will also be a one-off catch-up campaign for those aged 75 to 79 on the 1st of September 2024. We should also offer the vaccine to all women who are 28 weeks or more pregnant up to birth. And we should offer it in each pregnancy, regardless of the interval between pregnancies. Ali, you've got the Red Whale calendar, haven't you?
I have, yes. We've got coming up all sorts of exciting things as ever. If you're a GP trainee and you're looking at sitting your AKT, we've got the AKT Top Tips webinar coming on the 20th of November. And anyone who's a GP trainee or F2, if you're also an MDU affiliate or member, remember you can sign up for free access to Red Whale Knowledge and to these webinars using the link in our show notes. And we've got a new course launching on the 4th of December. It's our blood test course. So that's great for anyone who feels less confident with interpreting blood test results, or if you've got team members that are new to interpreting blood test results in their roles. And it will also, of course, be available to all unlimited members, and the bites will go on the site as soon as the course launches. So even if you're someone who feels pretty confident in most blood tests, you can look up those secret tricky ones. And we've got lots of women's health opportunities coming, both digitally on the 29th of November or face-to-face courses on the 6th or 12th of December. Might be quite nice to combine a day out Christmas shopping in London or Manchester with a little women's health update.
Cool, that sounds fabulous. Shopping and women's health, brilliant. Count me in, I'll go to both of those. Time now for our primary care superheroes.
So thank you for all your texts that you've sent in, and keep sending them in, please. So from 9806 on the texts, we've got Isma Ali, originally from the UK, but now living and working in Pennsylvania, USA. Hello to you over in the States. And from 1302 on the texts, Kabir Tombat, I'm halfway through the first year of GP training in the Netherlands, and I'm really enjoying the podcast. So great to hear that.
Excellent. Thanks for both of those. And 6528 on the text. Hi, I'm Joe, a GP ST1 just starting and working in Brighton. Smiley face emoji. Thanks for that, Joe. And 1006 on the text. Hi, I'm Claire, a GP ST3 in Lincoln. I've been listening since returning from my second maternity leave in June. The baby brain is real, but the pearls and podcast are brilliant. So thank you for that, Claire.
I relate to that baby brain a lot, Claire. I'm not sure it ever really recovers.
Oh, thanks for that. Okay, so now if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. So how do you become a member, I hear you ask? Well, if you are listening to us now, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code Red Whale Pod to get 10% off. And here's the small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, Red Whale Pod.
And if you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds of your time and we really appreciate it. If you can spare a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got value from listening to the podcast today, then please don't keep it a secret. Please tell everyone that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedWhalePod.
The other thing that you can do if you click on the link in the bio is to leave us a voice message. You might have heard some of those in recent episodes. Tell us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.